So let's talk about the principles of fracture management. Three of them: reduce, immobilize, and rehabilitate. So when we're talking about reduction, we're talking about putting the two pieces of the fracture together. Um, and that's your reduction. You can do it as closed, so a closed manipulation of a fracture. This may involve just manipulating the fracture. It's particularly good if you're talking about wrist fractures in kids. An open reduction is maybe necessitated in particularly the long bones, um, and examples of that could be an open reduction and internal fixation, which is normally done in hip repairs. And that term ORIF uh, puts together the first and second principles. Second being immobilization or stabilization. Now, under the bracket of immobilization, you can talk about sort of 5 different types of immobilization. You can talk about a continuous traction, which is rarely ever used these days, except in children. It's fantastic for children. Cast splinting. This would be your plaster of Paris, and the problem with that is that it's got stiff joints, so you end up with this loss of mobility, which may actually be sort of long term. And if you're talking about an elderly lady who doesn't use the limb anymore, may have had a stroke before, etc., that might be acceptable. But if you're talking about a young person who needs to go back to work, that may not be acceptable. So you balance these things. So that's the cast is excellent for sort of like spiral fractures, which could be a result of torsion force. Torsion force will give you a spiral fracture. So that's the first two, your continuous traction and your cast splintage. Third one we can talk about is the functional bracing. It's basically two casts across a joined by sort of like a hinge in between. So you see that when you're talking about, so you could use that if you're having some kind of knee injury or elbow injury. You could use something like that. Tend to avoid, but you could, it is an option. um, Finally, you've got the two most common ones, that is your internal fixation, your external fixation. You see your external fixation sort of like the bones. If you remember Dr. Strangelove, he had those bones which are external fixations. You can see them often in the legs, in the long bones again, your femur, your radius. But the trouble with external fixation and internal fixation is the risk of infection, because these are surgeries that you're asking people to undergo. So they bring the risk of infection, the risk of DVT or PE, pulmonary embolism. You can look that up. So they're not very safe. However, they have the fastest sort of off time, because as soon as the pain is manageable with your painkillers, post-operative pain management, um, you can get the patient out of bed. Whereas if you're using things like traction and using things like cast, patient needs to stay in bed, patient needs to be immobilized, the joint can atrophy and muscles can atrophy. So there are benefits to using internal fixation, external fixation methods which require surgery, but again, you weigh that off. A 98-year-old that won't likely benefit from surgery, especially if they've got several other comorbidities, whereas a 20-year-old may. But you balance them. Finally, you have rehabilitation, and basically, in terms from the doctor's point of view, it is um, referring to physiotherapy or occupational therapy, and they will take care of that. They'll want to mobilize the patient as soon as possible, put some ice packs to reduce any kind of effusions, get some exercise to increase venous return of blood, and those are all the benefits. Now, a few other things to note. We talked about the spiral being a spiral fracture being a result of torsion uh, forces. Other kind of fractures you can get is sort of if you have a compression of forces, a compressionary force, you can end up with a oblique fracture or an oblique fracture line. If you have an absolute transverse of like 90-degree to the shaft, if you have that, then it's probably a result of bending. You won't see that in children because remember, children have malleable bones, so it'll be like breaking a fresh branch of a tree. It has that sort of flayed appearance, and you can actually have a fracture on one side of the bone that doesn't get through to the other side of the bone. So it's worth keeping in mind about that. And then finally, you've got your high energy fracture. You'll see that it's comminuted or compound, several ways to use it. You can just see that it's a shattering of bone, and that is usually a result of high energy impact, somebody coming off a motorbike, road traffic accident, etc. So those are the different kinds of fractures, sort of like lines you can get on X-ray. Um, One emergency that you do not want to miss is compartment syndrome. Compartment syndrome is sort of like fluid buildup in each of the compartment tissues, and you treat it with fasciotomy. So if you're the A&E junior doctor, you want to be referring these people ASAP. You pick them up with they tend to have sort of disproportionate pain. So it's important to keep in mind what the patient has had in terms of painkillers, because I would have had a lot of painkillers for something that you think that is not, a fracture like that shouldn't be on such high dose painkillers. So worth keeping an eye out for that. There will be swelling as well in compartments. In certain compartments, you need to know where your compartments are. Also interesting is the progressive neurological signs or symptoms that if you see that could be pointing you to compartment syndrome. One other thing you do not ever want to miss is avascular necrosis. So you see it oftentimes in your scaphoid. So you want to palpate in the anatomical snuff box to make sure that you pick up sort of scaphoid fractures. These don't appear on X-ray, so always remember to come back 2 weeks after the fracture was done to look for your scaphoid fracture, which may have appeared by then. Your femoral neck fractures and femoral neck repairs are at risk of avascular necrosis, and that's why many a time people prefer a total hip replacement, and we'll talk about that when we talk about sort of like hip or orthopedics. And then finally, you have your talus as well. You find your talus in your foot, and that's your three bones that are at risk of avascular necrosis. So finally, to wrap this all up, it's probably worth mentioning the stages of bone healing that we see. It starts with a hematoma, inflammation, and that forms a callus. And once the callus has formed, you can have consolidation and remodeling of the bone, and that is how the bone repairs. So all the types of internal fixations, when we're talking about the intermedullary nails, when we're talking about the plates, when we're talking about the wires, the K wires, those are all stabilizing things. They help. There's like all internal fixation device. They help stabilize the bone so that the bone can heal itself, and that is what we really want to do. Um, Final point is osteoporotic patients who have fractures. You consider this fraction to be abnormal and an insufficiency fracture. If it's pathological, we're talking about things like it's tumors or abscesses, infection in the bone, metastasis. So any kind of pathological process that may have underlined that may have weakened the bone and made the bone more susceptible to fractures. Um, and then if it's a normal bone, you can call that a direct fracture. Hope that helps.